to start us off, can each of you maybe briefly describe your current role and how it intersects with the evolving role of PTs as frontline MSK providers?
So, I'm the head of clinical innovation and strategy at Prom Therapy Solutions. And what my role is really doing is I'm identifying the most pressing pain points across the rehab industry, from frontline clinicians to enterprise organizations, helping them navigate growth, reimbursement challenges, anything that's going on in the industry, and helping create solutions through technology to better those practices so that they can continue to grow and provide quality care. And with that, a lot of it comes with looking at innovative clinical models and practice models, again, to make sure that all of these companies are growing successfully and that the clinicians within them are able to do the work that they do best. So, PTs as primary care providers are absolutely part of that. We are industry leaders. We're trying to push the edge on how can we make this ecosystem industry better and improve. And we've identified that as a route and a way that we can help really advance the field.
Awesome. And Jeremy?
Jeremy Vandevender. I'm a physical therapist by background. I am currently focusing my time on a number of entrepreneurial endeavors, one of which being I started my own consulting growth advisory firm, Equus Growth Advisors, this year. I'm also a co founder of a longevity platform called Elevate X Health, which is focused on supporting concierge oriented physicians in developing a longevity based precision medicine practice. I am also a strategic advisor to a couple of different groups, one being Redesign Health, a venture capital startup fund that I work with, as well as Med Truly, which is a primary care provider for broad internal medicine in rural markets. So those are the three areas that I'm focused on. I've been a PT for 25 plus years. Prior to this chapter, I was the chief revenue officer for Ivy Rehab, where I led growth and development of that platform from 2016 to 22.
And so, how would you say that your current role intersects with the evolving role of PTs as frontline MSK providers?
So a lot of what I'm doing is really strategy oriented around the evolution of healthcare, and a number of the areas I'm playing in and advising on are working with emerging groups around digital technology and the interface within the musculoskeletal domain, and particularly around physical therapists having a expanded capability to engage with patients earlier on. So a real focus on positioning physical therapists to be in that seat as a primary care provider and having the tools to do so. Another part of my focus, and this really has come to light for me in my work in the longevity space, is that the absolute opportunity for physical therapists to evolve the way that they practice into more of a what we call a precision-based medicine environment, particularly where they're leveraging their extensive MSK skills on the front line to engage with patients on improving their overall health and wellness through the lens of MSK. So I've had a number of therapists that I've been able to connect with who are really passionate about this opportunity to evolve the way physical therapy is practiced through more of a subscription focused model and primary care position, leveraging their skills, their truest skills as leaders in MSK.
Interesting. And so now it sounds like you both are coming from somewhat similar, but still very different areas. So I think your insights will be really unique. And I guess what I'm wondering is, how would you characterize the shift in physical therapy toward a primary care or first contact model for MSK issues?
So I think it's long overdue and extremely necessary. We really transitioned to the doctorate of physical therapy back in the 2000s, and we were preparing clinicians for greater autonomy, including differential diagnosis, direct access, first line care. Yet the clinical model and the reimbursement model has not changed with those
Mm.
times. We still are really being those fee for service providers, treating patients visit after visit instead of really jumping into that primary care practitioner. And with all of the models going on now where we want to decrease the cost of healthcare, downstream spend, we want patients to get better faster, we want to be proactive. That's just the healthcare industry at a whole. Physical therapists fit that ecosystem so perfectly to be that primary MSK provider and to be able to see those patients and treat them before they get into injections, surgeries, and of course, help with that downstream spend. So we've been setting up for this for a while, but we haven't really been implementing it or really taking action on it. And the time is now because that space is open. Primary care providers are being burnt out and also are less and less. And you're seeing NPs in the space, PAs in the space, chiropractic professionals in the space. But really, it should be physical therapists taking on that role in the ecosystem.
Interesting.
Yeah, physical therapists, I think, are the best positioned providers to lead MSK care, and it's been unfortunate over the course of my career as I've watched physical therapy industry sort of sit back in the back of the room and kind of wait to be told what to do. And we've known this for a long time, even going back to when I was in PT school 27 years ago, and I didn't get a doctoral degree, and we were spending a great deal of time even back then focusing on differential diagnosis, focusing on understanding how to triage patients effectively through the MSK cascade. And I felt immensely prepared when I came out of physical therapy school, even with a bachelor's degree 26 years ago, to manage patients in this manner. And that's how I did it. My career thrived because of my ability to be the initial point person in MSK care and working with doctors who understood that I had that capability. And I always found, and I've continued to find that primary care physicians just aren't well positioned to manage MSK. They have very little training in that area. That if you talk to any number of primary care doctors, they'll tell you, as quickly as they can, that it's one of the areas of the least training in their medical degree programs, and it just doesn't position itself in the traditional primary care venue, and which is really surprising to me, and it's a huge opportunity for physical therapists because the number one area of healthcare spend in the United States is not on disease. It's not on um, you know all the areas that people think about where you have the highest proportion of death and disability. It really is in musculoskeletal. The amount of spend in musculoskeletal to manage injuries is profound. And the other part of this equation that's super important for us to remember is that these other severe diseases that affect lifespan, like cardiovascular, cancer, diabetes, they're almost entirely um, able to be positively impacted by movement and a positive musculoskeletal capability. So physical therapists have been prepared for this and sitting in this space for a long, long time. I think it's just time for them to flex their muscle and be willing to lead in primary care for musculoskeletal pain. They are the tip of the spear with respect to reducing costs. It's the lowest cost intervention that you can provide. It's non-invasive. Generally, patients really enjoy physical therapy, and I think it's going to be up to the therapist in this next generation to think along the lines of, I am a primary care provider, and I want to play in this space. And if we can get to that place, just from a mindset standpoint, I think we can completely evolve the way physical therapy is practiced, and that'll have a huge impact on burnout. That'll have a huge impact on reimbursement, huge impact on the opportunity for therapists to grow professionally and be entrepreneurial as well.
So now, with all of those benefits to having PTs in this role, what are the most significant barriers to them being more fully integrated as primary care MSK providers, whether that's clinically, legislatively, or even financially?
So I would say that the barriers is the way that the insurance is still reimbursing us in the fee for service model, and that the businesses are just following that model to get paid for their services instead of breaking out of it and really going after the value based care model. That's a big barrier. I would also say that another barrier is we are still under that realm of letting physicians refer to us and relying on that. We've done a lot better with direct access and going out directly to the consumer and the customer, but I still think there's some legacy systems out there that people are still doing what worked in the past. But if we don't keep evolving and changing, then just like any other field and industry, you're going to see a decline. So we do need to push ahead and actually create the change and let the reimbursement follow. We need to be the ones forging the way, calling ourselves doctors, making sure that we are treating as a primary care model, being at the top of our license, and seeing patients and getting them better quicker and faster instead of relying on, well, we should do the 12 visits length of stay because that's what we're getting reimbursed for, and we should follow that payment model. We should really break out of that and do the clinical practice model and let the payment follow.
There's a real educational gap here as well, that I've found pretty consistently in the educational training of physical therapists along the way, where PTs are uh, they're in PT school. It's a 3-year doctoral program. It's a they've expanded the educational focus over the last 20 years for the doctoral program, but one of the spots where academia is not caught up and does not really provide any insights or opportunities for the students is around entrepreneurship, business fundamentals, and you see that very differently in other professions. I'll use chiropractic as a perfect example. Chiropractors come out of school very attuned to be private practitioners, to build their business, to take risks, to understand how to sell. Physical therapists have just never really evolved to that state, and it's really unfortunate because we're continuing to put out therapists into the market with increasing cost of their degree and an increasing burden on their shoulders to pay for pretty substantial student loan debt that you hear constantly, and they just don't have the tools educationally to take on this challenge. And I think this is a call to action for academia to evolve the way that they're training their therapists through PT school and giving them more insights into how to be innovative, adaptive, entrepreneurial, take some risk. Because otherwise, it's exactly what Marla said. We have a traditional model of care, which is a referral based. I hope and pray that someone's going to send me a referral, and I treat that patient in a very traditional way. I haven't seen much in evolution of the way clinical care is provided around therapy programs over the quarter of a decade. I'm sorry, a quarter of a century. There's just not been a lot of innovation in the space, and the it's ripe for it right now. And it is reimbursement where we have not seen the reimbursement come through on that primary care focus, but this is an opportunity for therapists to jump out of the box and start developing cash pay models, subscription pay models, and telling the story to the patient community and the referral community that we can practice at a higher level, and we should absolutely be practicing at a higher level. This will bring the industry forward into a new domain.
So now, with all of that in mind, how should pre-licensure PT education evolve to better prepare clinicians for expanded roles in triage, diagnosis, and care coordination?
In the university setting, as Jeremy was saying before, you really should be setting these students up for success and the mindset you are a doctor, you're getting your white coat. They should be looking at more of the medical risk and red flag model, a little bit more at how to prescribe radiology and ultrasound and diagnosis. Um, you're seeing that happen in some states where Utah just passed a great legislative law about PTs as primary care providers. So having the universities and school academia follow to really set those therapists up for when they come out to be able to practice in that setting. There are residencies starting to come out as well. The APTA just put out a residency for primary care providers. I would recommend that schools start to promote those residencies, not just the ortho and the sports, but the primary care residency. And there are certification courses that the APTA has started to put out as well. Incorporating that into academia would be more beneficial than just telling therapists when they come out to go and take that advanced course. That should be part of their curriculum, and really setting them up to be that first line, frontline practitioner.
That is really insightful. And Jeremy, I want to hear your thoughts on it as well, but I also want to add another question to kind of deepen where we're going with this. So maybe could you also include what additional postgraduate training or credentialing you believe could be essential to support this model at scale?
Yeah, postgraduate training, it should be an onboarding of all companies that hire clinicians. It should be part of their onboarding. I would say the number one thing that I see done incorrectly is these clinicians come out and they do think they're doctors. They did get their white coat, but then whatever company they're part of doesn't call them a doctor. They don't introduce themselves as a doctor. So I would highly recommend that any kind of PT company, from the owner all the way down to the clinicians, start to make that change there and bring your clinicians on board as doctors. Call them that. Make sure they introduce themselves as, I'm Dr. Renary, I'm your physical therapist. So it's very clear what kind of doctor you are, but set the tone. And in the onboarding that therapist to your company, there should be this education and these pathways that we were talking about embedded in that onboarding process.
Yeah, I go back to I agree with everything Marla said that this is a absolute need of physical therapy companies, whether they have, 5 clinics or 500 clinics, to really embrace this evolving care model. I've actually found, generally speaking, the smaller companies are much more nimble and tend to be more willing to take this risk. And it's not surprising. I liken it to the difference of somebody out in the ocean who's on a 50-foot sailboat versus a 500-foot, superboat, where you can turn more quickly. You can, navigate out of the storm more quickly when you're on that small boat. You don't have to have planning your turn, 2 days in advance. And, it's a real call to action for the larger physical therapy companies as well out there to embrace the fact that there is a differentiated care model and to embrace innovation as a real foundation of the business. And, it's embracing innovation is hard. It's scary. And, especially when you've got a standard revenue profile, which is, as Marla said before, patient comes into physical therapy. I'm going to see them 3 times a week for 6 weeks. That's how we've always done it. I know how to predict my revenue, and I know what that's going to look like. And it's just basically staying in the same place. And when you stay in the same place for too long, eventually you start to recede, and ultimately you're going to see that impact the physical therapy industry as the patient expectation, the physician expectations start to evolve. But I still think it starts in physical therapy school. And this is something I'm trying to do personally. I reached out to my alma mater over the course of this year and said, I really truly believe that you need to have entrepreneurial education, business education for your students, regardless of what they want to do. It should be universal that if you don't understand the business of the industry you're going into as a provider, I think that you're really set up to struggle. And I do think that this is one of the reasons why you're seeing a lot of burnout in physical therapy. You're seeing a lot of people leaving the profession relatively early, and it's because they come into the world with a false set of expectations of what the economics will look like and what practice will look like. And if you're setting them up to come out of physical therapy with, in many cases, $200,000-300,000 of debt, and not truly understanding how that they can practice at the highest level, you're not serving the new physical therapist the right way as an academic institution. And I think it's really important for the physical therapy programming for certification bodies to start looking at this and saying, this is a problem in physical therapy. They don't know how to come out and be independent entrepreneurs. And it just sets up therapists to be kind of controlled and be told how they're going to practice rather than determine how they want to practice. And then it does follow, actively in the professional setting where therapists need to do exactly what Marla said: embrace the fact that they are educated this way, embrace the fact that they are the tip of the spear of musculoskeletal care, and get out there and be willing to change the model, because physical therapists are phenomenal at that. They just don't embrace it and understand how to navigate in these new choppy waters, and we need to help them do that through education.
And I would also just add to that, I think they need to be educated a little bit more about HEDIS measures and different measures that the healthcare industry is looking at for patient and population health, and how we can really help affect the ones that pertain to the musculoskeletal care. They need to be educated about that. They need to be educated about how the model itself shouldn't just be the therapist doing everything, from scheduling the patient to seeing the patient to every single session. There should be a care model. You go to your dentist, you go to your orthopedist, and you see the dental hygienist, you see the dental tech, you see the PA, you see the nurse or the RN, right? So right now, therapists are still doing every part of the plan of care, and they really should be focusing on the higher value tasks, that diagnosis, that treatment, that evaluation, and should be passing off to the team the rest of the tasks, because we do see reimbursement rates for evals going up, but it's all of those follow-up codes, Therex, manual, that's going down. We really, if we focus on those high value tasks and practice at the top of our license and share, letting the PTAs do some of that follow-up services, then you're really going to be able to allow the patients to understand that that PT is a doctor, and every single time they see them, they're giving the most highest valued care, and allow the model to work even better, so that those PTAs can carry out some of those sessions where you would quote unquote be just watching exercises versus really giving the skill that you've developed in school.
Yeah, Marla, just as she made that point, just really it reflects on me of some of the work we did together in our prior life when we were on the same team at Ivy. And some of the, I think the coolest work we did was around those the HEDIS measures, and really we dedicated ourselves 4 or 5 years ago as we started to really think along these lines of being more predictive, being more front of foot with respect to how to manage patients. And we've spent a lot of time when we were at Ivy and developing really smart predictive models that would identify patients and cascade them on the risk profile of likelihood to achieve their outcome measure. So, what it strikes me, one, is that we were able to get into that position because we truly embraced the need for outcome measures in our clinical practice, and how physical therapy historically has been really slow to adopt, and it's still incredibly slow to adopt outcome measures, like true objective outcome measures, promise, HEDIS scores that are insightful and allow you to objectively see the improvement you've had with patients. But as we dug deeper on that and we started getting to a place of being able to predict risk and identify a patient on phenotypes of their most the to create algorithms for them to have the best outcome of care. What we started doing that was really fun, and Marla and I had a number of these experiences. We started going out on academic tours and teaching this to PT schools. Started with my alma mater, Rosalind Franklin, here in Chicago, and the engagement we had with the students teaching these classes was insane. It was so cool to see them really understand that, okay, you've got this whole picture of how to manage patients, but now we're going to talk about how to proactively manage patients using data and thinking more along the lines of a doctor and a frontline provider. You could just see the light bulbs go off amongst the students in the class, and it was really fulfilling to me to be able to have those conversations. And I think this goes back to the point that academia has to embrace frontline practice and leaders in practice who have real life experience that they can come back to their schools and share. And it also is beholden on therapists across the United States to engage with their alma maters and take back their learnings in real practice and share that with the next generations of students, and to be involved in teaching those real world skills around business, around outcomes, et cetera. That's going to move the needle significantly, and it's going to create a better landscape of therapists coming out of school who can understand how to operate in this manner.
Now, you touched on something there that made me curious. What do we know about outcomes when patients access PTs first for MSK conditions compared to the traditional referral pathways?
Well, the data and evidence shows that PTs as the frontline providers does provide better outcomes than a primary care doctor or an orthopedist. A really good study came out from Johns Hopkins, and it was actually a HEDIS study that showed 96.7% of PT initiated low back pain visits avoided imaging in the first 28 days versus 82% for primary care providers. There was another study done by Horn et al., and that looked at outcomes in a direct access PT model versus physician referral. And that showed that patients who accessed PT directly had faster improvement in function, shorter episode durations, fewer follow-up visits. And another really great one by Childs et al. Looked at early physical therapy management for low back pain and showed how it reduces utilization. Finding early access to PT ended up being associated with reduced use of spinal injections, fewer surgeries, and lower imaging rates. So, I mean, you can go on and on. The data is out there, the research is out there. It shows time and time again that PTs as that frontline provider, and the quicker you get in to see a PT, does decrease that risk of surgery, injections, and overall outcome. But PTs need to be better about tracking their own outcomes. These are research studies that are put out. Every single PT and PT provider and company should be absolutely measuring, gauging, and evaluating clinicians on their outcomes measures, and should be very strategic in how they're showing that. As we said before, there's promise measures, there's HEDIS, there's patient reported outcomes measures. There are a lot of ways to do it. And now as technology is advancing, even with RTM and some other different resources, we have to be able to show that and report that back, because that's where we're losing with insurance companies. We're not doing a good job taking claims data and showing the value of what we're doing with patients. So they're seeing the overall that a therapist may have seen a patient for 20 visits and looking at that as a really long stay for a potential outcome that they don't know about. We have to show that we can do it in a faster amount of time, a more efficient amount of time, and we can do it with proven outcomes to report back.
Yeah, I think this is one of the most important things in the future of physical therapy there could ever be, that every provider should embrace objective outcomes. It shouldn't be a conversation of haves and have-nots, of who have an outcome reporting capability across their business. It shouldn't be the haves and have-nots of, we don't really focus on that. We just do net promoter score. Net promoter score is nice, but there's nothing objective to net promoter score. And when you go to a payer and say, my net promoter scores are 97 out of 100, that's a nice data point, and it does suggest that you have really great customer service, and that's super important in what we do. But absent a true objective measure and being able to tell that story, you're just not in the right position to compel a payer or an institutional group as to the value of physical therapy. And we have to make this a mandate of the physical therapy industry, not just individual providers or large provider groups. I mean, I put this back to the APTA and the APTQI, the groups that are advocating for and lobbying for physical therapy. There's a whole lot of discussion points out there. I think there's none more important than validating the strength of physical therapy to not just make patients better. That's great to make patients better, but most importantly, as you think about this and what's going to get primary care physical therapists paid, is proving to the market through real data, claims data, actuarial information, that patients who get into physical therapy within 24 to 48 hours of their onset of symptoms have a substantially lower cost of care downstream around prevention of advanced imaging, injections, um, any invasive procedures. Obviously, surgery is the worst outcome. But even, we talk a little bit on the fringe around things like opioids and medications, but I've not seen this really broad adoption as an industry that is, this is the essence of what physical therapy is here to do. We are the frontline provider for musculoskeletal care. We will reduce overall cost of care and invasive and more uh, non-sustaining interventions like use of drugs. And we've got to do that as an industry. We've got to do it as organizations, and we've got to own this and do it through leveraging outcomes and doing research that proves it.
And that makes me want to touch on something that you mentioned before as well, talking about payers. So, how could you foreseeably imagine either reimbursement or payer dynamics supporting this shift in care delivery?
It's messaging to me. I led payer relations for 5 years at Ivy at scale, and I was the person having the conversations with the payers over and over and over. And Marla was there with me a number of times, having meetings with large payers and really trying to dig into this. And what we always found, and it's not a failure per se of the individual company. It's a challenge that it's really hard to get your arms around the claims data and to separate out the claims data as to what was the impact of physical therapy on the overall cost of care. And you can't expect insurance companies to do that for you. You've got to be able to do that yourself. And I think embracing actuarial data, embracing real market insights, and working with consultants who can go under the covers a bit here and truly understand what the cost and the impact on cost is. And at the end of the day, you've also got to take a risk. And part of this is I'm willing to take the risk that I'm going to change the episode of care to something like, we'll do 6 visits and a case rate and be able to operate within a case rate environment and take the risk on your shoulders as a provider that you can get the patient better more quickly and that ultimately you will win because the patient will be happier, the outcome will be better. Now, one challenge I found in this, and this is where insurance companies, I think, have to catch up, and this could be a massive transition for the entire industry, is rewarding therapy companies for having great outcomes and reducing overall cost of care. We haven't seen that. There's not a lot of impetus to providers in the space right now to reduce their length of stay, the number of visits they have for referral, because all that does is take revenue out of the business without referrals coming in. So there needs to be a scenario whereby insurance companies, value-based care providers, ACOs, physician groups who are looking at outcomes and looking at cost are able to refer more patients to the best quality providers. And I think that ultimately we need to get to a place where you can put your outcomes, your quality out there for the consumer and for the payer to understand, and that will rate you as a higher level provider and allow you to have an opportunity for more patients to come through the doors. That's a bit down the road, but it's going to have to start with therapists being willing to take that risk and really embrace data and share their data, write about it, tell the story, and break through the walls of people who are trying to not pay us more. Because that's not going to stop. We have to change the way we're paid, not ask for more money.
And I'd say there's a perfect place where we should live in the reimbursement ecosystem, and it's under the non-physician practitioner under CMS. So that includes nurse practitioners, physician assistants, and clinical nurse specialists. We as physical therapists and physical therapy industry need to fight and push for us to be reimbursed under that ruling and be put under the non-physician practitioner. That's really where I feel that we belong as frontline leaders and being able to treat musculoskeletal injuries. And so if we can all align to rally against that and to use our legislative power to get us to be put under that bracket, then the reimbursement rate should follow as what an RN and an NP and others under that non-physician practitioner model.
There's something Marla talked about a minute ago that struck me, and it's kind of a personal experience myself that I think is really important. Physical therapists have not embraced the role as the leading provider in the industry, and have not really done a great job of effectively aligning practice with PTAs and managing their cases in a way that allows them to operate top of license. And I actually posted about this in a comment on LinkedIn the other day when I was talking about military medicine. Someone mentioned that that military medicine is a proxy for how physical therapists can operate in the civilian environment at their top of license. And I had that personal experience. My last affiliation in PT school was with the Navy and the Marines, and I had the chance to work at Parris Island at a naval hospital down in Beaufort, South Carolina, and a Marine Air Base. And the role I was in there, and it was amazing as a PT student working under the supervision of a Navy lieutenant therapist. I was a primary care therapist 26 years ago. All I did was evals. I would do 10 to 15 evals a day, and that was my job. And the patients come in, and it was evals and reevals, and then I would dictate the treatment, and I would prescribe that treatment. And the tech, as it's called in the military or the Navy, is the equivalent to a PTA in civilian. And they would do all the interventions, and I would see the patient for the follow-up. Now, it wasn't that I was hands off and not engaged in the intervention. I was acting as a primary care doctor would, where I would be checking in with the tech, making sure that those patients are progressing the right way. And I was looking at this much more from a triage standpoint. Also had the luxury in that role, and it's an amazing experience in the military. You can prescribe meds, you can prescribe and order tests, and you can be involved in reviewing tests. So we operated in that way. The military operates in that way. Therapists can do this. But it requires understanding how to navigate that interface between PTs and PTAs and using your team in the most effective way, because there's no question that doing day-to-day relatively rudimentary interventions and treating patients hands-on as a physical therapist is not the number one use of a physical therapist's skills. Physical therapists need to be diagnosticians. They need to be evolving and guiding clinical practice. They need to be standing a step back and looking at how these patients are progressing and then using their clinical expertise to guide that progression. And if we could evolve the way that civilian practice is being done to the way that it's been done in the military for 30 plus years, it'd be a massive win for the physical therapy industry, and it would position therapists to practice entirely differently, and I think to be a lot more fulfilled and a lot more effective in their roles.